So, diabetes is becoming a global health issue with large burden on economy and healthcare. Various modalities of treatment are now available for management of diabetes, but somehow all these modalities are not reaching the very peripheries of our country. There are many issues behind this, all of which cannot be addressed. But one issue that can be addressed is that the practitioner who is living in the far periphery with limited resources can be made aware about the very basic of diabetes and its newer modalities. What this will do is that this will help the population at large and will decrease the complications if started, if treatment is started early as well as properly. So we will start a series of lectures keeping in mind the various basis of diabetes as well as the newer modalities that are coming in mind. We will try to make these lectures entertaining by keeping lot of cases in discussion and not discussing only the theory part. So to start with, let's start with the definition of diabetes. A very basic definition of diabetes is that it is a group of metabolic disease. It is a group of metabolic disease. That means group because there is type 1 diabetes, there is type 2 diabetes, there is maturity onset diabetes of young, there are latent autoimmune diabetes in adult. There are many forms. So it is a group of metabolic disease that is characterized by hyperglycemia. So there should be raised sugar plus there should be long term damage from this high sugar. So long term damage, we all know the complications. There are acute complications, there are chronic complications. So this hyperglycemia should be severe enough to cause long term damage. So it is very simple. What is diabetes? The very layman people also know that diabetes is increased sugar, right? And this increased sugar will eventually cause complications. So we have to decrease this. So let's see what ADA has to say. How and when will we diagnose? Because definition, nobody cares about definition as long as we are not able to diagnose, right? So there is a diagnosis criteria. So there should be any one of the following. There should be any one of the following. Now every point is very important and it is usually wrongly interpreted, right? So number one, let's start with fasting blood sugar, right? First, what is fasting? What is fasting? Fasting is, in this scenario, no oral intake, no oral intake for more than 8 hours, right? At least 8 hours period where there should be no intake of food, no intake of food, as well as any small snack or tea, right? So if there is 8 hour of fasting and you do a plasma, right? It's a plasma sugar, not a glucometer sugar, right? Not a glucometer sugar. This is very important because what happens is somebody is in the family is having diabetes. He is having a glucometer, and his or her son, daughter, somebody, the family gets sugar done and it is high. Maybe it is 140, and patient is being labeled as diabetes, which is wrong, right? So this is the very first point of learning, that 8 hours of fast plus plasma reading is important, right, to diagnose as diabetes. So this is number 1. Then let's see point number 2, right? Very important point number 2. This was point number 1. Then point number 2 is 2-hour plasma glucose more than 200, right? So after 2 hours of taking a OGTT. What is OGTT? Oral glucose tolerance test, right? The sugar, if it is more than 200, then it can be labeled as diabetes. Now, what is this OGTT? This is important, right? Because it is wrongly done. What is done? When we are actually talking about like very strict guidelines, like 199, I am saying this is not diabetes. This is something else. 200 mg, this is diabetes. When I am talking about such strict guidelines, I need to be sure that if guideline is saying 75 grams of anhydrous glucose, it should be 75 gram, right? If I am giving 80 grams and sugar is coming out to be 200, and I am saying this is diabetes, then I am doing wrong to the patient, right? So what basically is done in an Indian scenario is 100 gram or 125 gram of glucon D is taken, and then approximately 2 large spoon is taken out, which is a wrong procedure. So what we need to do is we need to measure it, right? And when we measure it, it should not be 75 grams. It should be somewhere about 81 grams, because if you will check the box, it is 100 gram of this glucon D provides something 90 gram of anhydrous sugar. So this is important, always check the label, right? So take 81 or 82 grams out, and then give it in 1 glass water. Let him drink, let the person drink it over 5 minutes and wait for 2 hours, right? Then if it is more than 200, then it is the second criteria. So it is very simple, right? No confusion. Fasting, 8 hours fasting, sugar more than 126. 2 hour after 75 gram anhydrous glucose, sugar more than 200, and HbA1c more than 6.5. Okay? HbA1c, again, third point about HbA1c. HbA1c should be taken from a NGSP certified lab. What is NGSP certified lab? NGSP is National Glycohemoglobin Standardization Program, right? It was basically this DCCTS. DCCT is Diabetes Control and Comparison Trial. This trial was done, and the labs that are NGSP certified, they are doing this HbA1c as per this guideline, right? So it's not like any lab should be there, and point of care HbA1c testing is not allowed, right? So this is very strict. When we have to label someone as diabetes, we should be very sure that it's a diabetes. And then there is number 4, that is, what is number 4? There are typical sign and symptom of hyperglycemia, and random blood sugar is more than 200. Then what are the typical signs and symptoms of hyperglycemia? They are they are polyuria, polydipsia, and unexplained weight loss, right? If somebody is presenting with increased thirst, is going to washroom again and again, again and again, and saying that I am eating a lot, but I am losing weight, right? So this may be a symptom of or a start of diabetes, right? So all you need to do is a random blood sugar. If it is more than 200, label as diabetes, right? So this is about labeling of diabetes, which is important. Now if you will check the table given in Harrison's, again it is same. More than 126 after 8-hour fasting, this is important, 8-hour fasting. Number 2, more than 200 after 75 gram, 2 hours after that, right? And HbA1c more than 6.5. Then what is normal? Normal is fasting less than 100 and 2-hour postprandial less than 140, HbA1c less than 5.6 from a DCCT certified lab, right? DCCT certified lab according to NGSP criteria, right? Between this is what? This is pre-diabetes. So when the fasting sugar is between 100 to 126, it is impaired fasting, right? It is impaired fasting glucose. You can see here, if you take some glucose, that is you take some food, and after taking food it becomes 140 to 199, it is impaired glucose tolerance. What is this? It is impaired glucose tolerance, right? And also for HbA1c 5.7 to 6.4. Now remember, these are not the targets, right? If a patient comes to you and he says, uh, doctor, he says, doctor, I started taking medicine, right? Now, what should be my fasting blood sugar, right? So you should not say it should be less than 100 because that is for normal, right? There are some given, targets given that should be achieved, and they are basically also depending upon age, right? But if you have to give one target, then fasting, you have to say it should be between 80 to 130, right? Give a range. Otherwise, patient says my sugar is fluctuating, right? You said less than 100. Sometimes it's 110, sometimes it's 70. It's not good. So you say this is the targets given by ADA, right? Indian guidelines says less than 115. Okay, this is the fasting target. So you say your sugar should be less than 150. Now you say better, it should be between 80 to 130. He says after food, right? After food, what should be my sugar? So you should not say less than 126. That is for normal, like for normal people who is not diabetic, who is not pre-diabetic, right? Sorry, less than 140, right? You have to say between 140 to 180. This is the target. And if you'll go with Indian guidelines, it's less than 165, right? So this was something about the diagnosis of diabetes. About the diagnosis of diabetes. Now, diagnosis. Let's see some examples, right? And let's discuss should we define this or not. So this was a 48-year-old male, right? 48-year-old male. He comes to you and says, doctor, what happened is that my father is having sugar, right? And I was doing his blood sugar, and I thought let's do mine, right? So I did it, and it came out to be 202, right? 202. So I was very scared, right? But I remember, like, whenever you call my dad, you say like you have to do a fasting sugar. So I fasted overnight, right? I fasted for more than 10 hours, and I did my sugar again in a glucometer, by the glucometer, and it came out to be 148. Am I diabetic? And there are two type of doctors, right? Two type of physicians. One said, like, yes, you are diabetic. Why are you diabetic? Because your sugar is more than 140, fasting sugar. You are diabetic. Other one said, no, you are not diabetic. What you have to do is to get it done from plasma, right? Plasma blood sugar should be done. So once you did the plasma blood sugar, it came out to be 98 mg per deciliter of fasting blood plasma, and he was not actually diabetic, right? But he was very scared. He did all the other investigation, and it came out to be HbA1c more than, it was 4 point, it was 5.3. Postprandial blood sugar was 129, right? So it was clear cut a case of patient who was not a diabetic, right? But if somebody would have said he is diabetic, then he would have started him on metformin. That's what happened in peripheries, right? Metformin or maybe glimepiride, right? Or maybe metformin 500, and he would have been taking this medicine forever, right? He would have said, yes doctor, you started me on metformin, now my sugar is controlled, thank you very much, right? But he was wrongly started on metformin. So this is one of the example, right? Another example could be a patient, maybe a 51-year-old female, right, coming in with her battery of test done, battery of test. Why? Because some XYZ lab said that in 1299 rupees I'll give you all investigations, right? And what she found was a HbA1c of what, 7, right? She found an HbA1c of 7, and you said, oh, diabetes. And also she had tried all the instruction below this 7, right? You can have a chronic kidney disease, you can have X Y Z, right? So this was not a DCCT sponsored lab, not a sponsored DCCT SA recognized lab, and it was not a NGSP as per NGSP standard, right? So you repeat the fasting, it was 88. You repeat the HbA1c with a good lab, and it was 4.9. So all these things happen, right? So we should not falsely start a patient on diabetes treatment, right? Because once the patient is in diabetes treatment, he is a labeled diabetic. And once he is a labeled diabetic, he or she is a labeled diabetic, then it is very difficult to say no, you stop all your treatments, right? So it is a only take home message from this video, right? The only take home message is, what should you take home, right? That tomorrow onwards, whenever I go to the OPD, right, before diagnosing a patient with diabetes, be sure that he or she is a diabetic, right? There are many centers not having HbA1c, and it is not only investigation that is required, right? There are three other, right? Fasting 126, postprandial more than 200, right? And then HbA1c 6.5 is only one of them, right? So there are other three, right? Oh sorry, random blood sugar, one of 126, more than 126. So we should not always rush to diagnose a patient with diabetes, right? Plasma. So this is the take home message. And there are also a lot of things that we will learn forward, like all these patients, they want to get followed up again. A lot of doctors are saying you should follow up yearly, some are saying you should follow up after 6 months. So all these things, that how you should confidently say that you have to follow up after maybe 3 years or 5 years, what is the guidelines say? Okay, we will see about this. Thank you. Thank you for listening. Enjoy.